Hello everyone, myself Dr. Namrata Vitlani. I am practicing as a physician in Surat. In this video, we will discuss regarding the diagnostic criteria in detail of acute rheumatic fever. So the diagnostic criteria for acute rheumatic fever, that is the revised Jones criteria. So we require two major criteria or either two major criteria or one major and two minor criteria to establish the diagnosis of rheumatic fever. First we will discuss regarding the major criteria. So first is the polyarthritis. So arthritis in acute rheumatic fever, it is typically migratory polyarthritis which involves mainly the large joints, that hip, knee, elbow. All those small joints can also be involved. There are painful, tender, inflamed joints which shows a very good response to the NSAIDs. We give high dose salicylates, that is aspirin, in a dose of 75 to 100 mg per kg per day, that has to be tapered over weeks. And so migratory polyarthritis with good response to the NSAIDs, and that does not usually have any residual sequelae. Now after arthritis, next is the carditis. So carditis in acute rheumatic fever, it is usually the pancarditis that involves the all three layers: endocardium, myocardium and pericardium. And valvulitis, it is the hallmark of the cardiac involvement in the acute rheumatic fever. In the valvulitis, the mitral valve involvement being the most common. In the mitral valve, the mitral regurgitation, it is the most common manifestation. Patient may present with the fever, dyspnea, palpitation, or if complicated with heart failure, the symptoms of the heart failure may also be evident. Now on examination, soft S1, apical systolic thrill or apical holosystolic murmur at the apex, often radiating to the axilla. So the murmur of mitral regurgitation, it might also be evident. There might also be next common being the involvement is the aortic valve. Out of them, aortic insufficiency or aortic regurgitation, it is common. So diastolic murmur of aortic regurgitation in the left sternal border, that might also be seen. As such, isolated involvement of the tricuspid and pulmonary valve does not occur in acute rheumatic fever, although it may occur secondary to the development of the pulmonary hypertension. Say for MS with MR, which leads to the pulmonary hypertension, tricuspid regurgitation, in that way secondary involvement is more common. Now in the pathology of carditis, over a period of year after acute rheumatic fever, as a result of the valvular damage, there occurs cuspal, caudal and commissural thickening. So there is a thickening of the valve leaflet, restricted mobility. All these findings that might also be evident on echocardiography. So over a period of around years, say for 10 years, stenotic lesions such as mitral stenosis, aortic stenosis, so multivalvular involvement and RHD, it may result. So over a period of time, rheumatic heart disease with multivalvular involvement, say mitral and aortic valve involvement, MS with MR, or with aortic valve involvement with secondary involvement of the secondary pulmonary hypertension, it may also result. So carditis, it usually leads to the residual sequelae and may lead to the development of the rheumatic heart disease. Now next is the erythema marginatum and subcutaneous nodules. These are also the major manifestation. And fifth is the chorea. So in chorea in acute rheumatic fever, it is termed as the Sydenham's chorea. They are the involuntary purposeful movements which is more common in the females, mainly prepubertal females. So in that there occurs involuntary movement or involuntary contraction, and the movements, they are purposeful. There is inability to maintain the sustained contraction of the hand and inability to maintain the sustained grip that results in the milkmaid sign, so called milkmaid sign, pronator sign. There occurs inadvertent protruding of the tongue and involuntary contraction, which is termed as the check-in box phenomenon, and stacco speech. So all these are the choreo features of the chorea which occurs in the acute rheumatic fever that responds to antipsychotics such as haloperidol, risperidone, and sedatives also. Now come to the minor criteria. In minor criteria, first is the fever, then laboratory manifestations like raised ESR, CRP, then leukocytosis, ECG findings, prolonged peer interval or first degree heart block, and with this we need preceding evidence, recent evidence of the streptococcal infection or recent scarlet fever in form of the positive throat culture or positive streptococcal antibodies, that is anti-DNase or anti-hyaluronidase antibodies. So either two major criteria or one major and two minor criteria plus preceding evidence of the streptococcal infection in the last 45 days, they need to be present. Thank you.